So this is quite a switch. We're going to syncope, a little different than hip fractures. And this is a relatively brief chapter, and it covers a couple of issues. But before we get to the individual articles, and by the way, some of these chapters, I think it's worth going in detail over some of the articles. And some of them, we're not going to spend a lot of time on the individual things and just go over the concepts. From time to time, I'll mention an article I think is particularly good and you may want to look at. But in general, I'm more interested in sort of the big picture idea. And, hopefully what I'm telling you is actually contained in the papers. And if you want to look at the details, you can. But I promise not to make up most of the things that I'm saying. So syncope, what's the issue with syncope? What are the problems that we have? So if somebody comes into your department or comes into the office and has had an episode of passing out or almost passing out. So first of all, what's the difference between passing out and almost passing out? Yeah, so I mean, but does it matter? What's the clinical difference? Somebody comes in, I felt like I was going to pass out, and I sat down and I'm okay. How is that different than passing out? It's not. They're exactly the same. It's really important for us to understand that. It's a little bit like, the room spinning. Well, it wasn't the room that was spinning, I was spinning. Well, they're the same thing. It doesn't really matter. Sensation of movement is a sensation of movement, and it comes from the same sources. And the same is true for this. And what we're worried about, so why is it the same thing? What is the issue? What is the problem that we're dealing with when somebody comes in with syncope? Why do we make a big deal out of it? What are we worried about? We're worried about an arrhythmia. That's what we're worried about. There's a million potential causes of syncope, but what we're worried about almost exclusively is an arrhythmia. And it doesn't matter whether the arrhythmia lasted 12 beats of VTach and you passed out, or 8 beats of VTach and you felt really, really like you were going to pass out and then you didn't. It makes no difference. They're exactly the same thing. So syncope and near syncope, we should talk about the same. Let's also, while we're at it, we should mention that sometimes people don't talk in those terms. They often talk about things like, I felt dizzy. What's the most important question you need to ask when somebody says dizzy? What do you mean? Really, really, really important. What do people mean when they say dizzy? There are 4 things they can mean. One is sensation of movement, vertigo. What else? Which?
Lightheaded.
Lightheaded. What does that mean?
Just feeling weak and like you're going to pass out.
Like you're going to pass out. Near syncope. That's number 2. Number 3 is cerebellar. Loss of balance. I stand up and I feel like I'm going to fall over. That's a different thing. And the 4th is none of the above. And the good thing about none of the above, which every one of us has had, who's ever had anything to drink, or when you have a viral infection. I mean, we've all had this sensation without actually any of those other things. It's sort of this non-specific, my head's buzzing, I don't feel quite right, I feel sort of strange in the world. That's very, very, very common in the elderly. Happens all the time in the elderly. In fact, it happens so much that there's something called the geriatric dizziness syndrome, which is just that. And the good news about it is that it never turns out to be anything. Okay? It doesn't have any predictive value for anything bad. So, what does that have to do with syncope? Well, syncope is one of the things that they can mean. And I think it's really important for us to try really hard to figure out what they mean. Okay? Now, sometimes it's impossible. Sometimes they just won't tell you. But this is one of the critical things. They don't often say, I passed out, or they may not say that. They may say one of these other terms. You really got to ask. And by the way, when you ask, doesn't mean you tell. It means you ask. If you put the words in your mouth, was it movement, was it falling over? They're going to say yes to all of them. So, it's hard, but we got to try to let them tell us as much as possible. So let's go back to syncope. What are the causes of syncope? What's the big picture causes? So we already mentioned cardiac. How often does that occur? 10%, exactly. What else? Vasovagal. What is vasovagal? Who knows? That's a term we made up so we feel better when we have no idea what it is, right? Well, we have some idea what it is, right? They get a vagal reaction that occurs when in some classic situation, you're getting your blood drawn, etc. And you get your heart rate really slows down, and you get lightheaded, and you get nauseated and sweaty. okay, there are a bunch of things you could have with it could be vasovagal, but we've extended this to, I don't know what it is, so we like to give an explanation. So in the old days, vasovagal was actually, used to be, in all the old syncope literature, it was more than half of syncope. It's been replaced now by another bogus condition. What's that? Neurocardiogenic. What is that? It's sort of like, well, here's how they did it. This is really great. Any of you have ever seen a tilt test or done a tilt test? You know what a tilt test is? It's a special table. It's really marvelous. You lie down on the table, and the table is like out of Star Trek. It goes from 0 to 180 degrees in a nanosecond. You're lying there, and it goes zip, and you're up. And then they ask you, do you feel dizzy? And some people actually pass out. And it's now more than 50% of syncope is due to this tilt table possible thing. The only problem is that the guru of syncope, this guy Vishwa Kapoor from Pittsburgh, did it on normal people. And 60% of them passed out. So I think this is, we in medicine, we don't like when we don't know what's going on. And this is one of those things where we often have no idea what it is. And so when we have no idea, we like to make up an explanation. So we make up things like vasovagal and cardioneurogenic. And my favorite is micturition syncope. I really love that. I was peeing. You were peeing? My God, no one's ever done that before. I mean, it's sort of like, you ever have a patient who comes in and they have abdominal pain or diarrhea? What do they always say when they come with diarrhea? Of course, I had chicken. It was the chicken. You know what? Everybody eats. But as human beings, it's not just doctors, all of us want to have an explanation, so we make up things like that. How do you know if it's food poisoning, by the way? What are the only ways you can really tell if it's food poisoning? Everybody else who ate that thing got it. That's the rare history. It's usually everybody else didn't get it, but I was lucky. That's the only way you can do it. There is one other way. I occasionally have the patient who comes in and says, well, I just discovered there was this egg salad that I left out in the yard in the 100-degree heat, and it was really smelly, so I tasted it. Okay, that one I'll buy. But anyway, so there's a whole bunch of things that you could either say, I don't know what caused it, and this is the majority, or you could make up names for it, but it doesn't really matter. Because what really matters is we're looking for the bad one. There are a few other things that we're going to talk about in a second, like, for example, neurologic causes. It's not really syncope, it's usually a seizure, and sometimes it can be very hard to distinguish. What are some of the best ways to distinguish? Loss of bowel and bladder. Okay, good. What else? What?
Tongue laceration.
Tongue laceration. They bit their tongue. Good. What else?
Postictal state.
Postictal state. To me, that's the one that really matters. Often you can have, we've all seen seizures where you're looking at it and you're not sure if it's a seizure or not. It's not that easy. When it's classic, it's easy. But sometimes seizures can look a little difficult. In addition, with syncope, particularly when there's hypotension to the brain, they will have little shaking movements. That's very, very, very common. So these can be very easy to mix up. Seizures usually has a prodrome. They have an aura. Most seizures have an aura. And they have a postictal state. If they wake up immediately afterwards and are normal, it ain't a seizure. It's impossible. The seizure is the brain doing all sorts of unnecessary electrical activity. The brain takes a little bit of time to wake up from that. Very often it takes a lot of time. So anyway, seizures, can be mixed in there. What are some other causes of syncope? The first few articles talk about major diseases that cause syncope that we haven't talked about. PE, good. We all know that, right? It's part of it's classic for PE. What else? Subarachnoid hemorrhage. A couple articles about subarachnoid hemorrhage. Okay, and it's actually a whole bunch. Ectopic pregnancy, you all know that, right? We're always supposed to, in a young woman who has syncope, look at ectopic pregnancy. So think about that for a second. Are any of those correct? What's wrong with the concept? So what is syncope? What's happening with syncope? There's transient decreased blood flow to the brain. Why do you have that with an ectopic pregnancy? What? You're bleeding. You're hypovolemic. Why is that transient? Did you get a transfusion? If you really think about it, syncope is very different than altered mental status. I see all the time people getting glucoses in syncope. That makes no sense. If your sugar is 12 and you pass out, it doesn't then correct. You're still out. The same is true with sodium. It's really important to get a sodium in somebody who's altered because the clinical manifestation of sodium, of hyponatremia, isn't. There is none. There's no way to tell. You cannot tell when hyponatremia is the cause of altered mental status. But hyponatremia is not the cause of syncope. It's not a transient event. So transient events, there's all this mythology about all these big bad diseases that cause syncope. It is true that hypovolemia can be associated with syncope. Why? Because what happened is you're like this, you're not getting enough blood flow, then you're like this. Once you're down, now you get more blood flow to the brain, you can wake up. But this is not occult. These are not things that are occult. So in general, and you know, there's an explanation why you can get it with a subarachnoid and why you can get it with a PE. And they do occur occasionally, but it's very, very rare, and it's not occult. So basically what we're left with is a lot of people come with syncope. Most of them have nothing. A few of them have a life-threatening condition. If we don't find it, they're going to die. So that's a tough problem. And to make it even worse, of the ones who have the life-threatening condition, most of them we discover right then and there. You look at their EKG and there's something very abnormal or their monitor, or we don't discover it at all. So the issue with syncope is that there's a common event, happens a lot. Most of the people who have something wrong, it's obvious. Of the ones who look fine, most of them are fine, but a couple of them are going to go die. So that's really scary for us because you don't want to send them home because if they go die, you don't look so good. So that's the problem. But when we admit them, what happens? They get hooked to a monitor and they sit there for a day. And if it is an arrhythmia, what's the next thing that happens? They sit there for a day, nothing happens, and then what? They go home and they die. So it's a really big problem, and there's no easy solution to it. Okay? But one of our jobs is to figure out who's at high risk for one of these bad events, and how can we figure them out. So the first couple articles, again, talk about a lot of the stuff we've talked about. What's the epidemiology of it? What are some of the conditions that can do it? Let's talk about the workup for a second. So the workup, again, I don't have to tell you how you figure out an ectopic pregnancy. When this is hypovolemic syncope, it's usually pretty obvious. We can figure out what's going on. They're lightheaded when they sit up. That's a help. They're tachycardic. They look pale, et cetera, et cetera. And it's just, you don't have to be bleeding, by the way. Of course, much more common is they're on a diuretic or something like that. But so here you have the patient who has syncope in front of you, looks fine. Okay, we're going to put them on a monitor, do their vital signs. That's really important. We often find something. What are the other things you do that are going to help you figure out what this person's got? An EKG. An EKG should be pretty much a no-brainer in syncope. Now, oh, by the way, let's go back for a second. There are some conditions of syncope where we know it's a benign cause, right? So the person went to get their blood drawn. Every time they get their blood drawn, they get really hot and sweaty. They felt really bad, and then they passed out. Okay, do you have to do any workup on that? Probably not, right? You're just sort of making it up as you go along when you do a workup on that, okay? But in general, for all the things we're going to talk about in the next few days, where there's some bad causes and some not so good causes, the issue isn't can I identify a benign cause, it's can I rule out a bad cause. Because we can always make up a benign cause. They were peeing. That doesn't matter. What matters is can you rule out a bad cause. So except in the very obvious case, the person has been standing in the sun for 4 hours and then finally got lightheaded and fell down. Outside of those few cases, we're going to do the same thing in everybody, which is look hard. So we're looking for signs of an arrhythmia. So what should we look for on the EKG? By the way, some of these people have a heart attack. That's when you're most likely to have an arrhythmia, or they have ACS, okay? But this is not a cult, right? Usually it's not a cult. Heart attacks can be hard to find, but usually when it's enough to cause syncope and they've had an arrhythmia, usually you know what it is. But so if they see ST elevation, I'll give you that one. But that's not the one I'm talking about. What else do you look for on the EKG? Heart block, okay, so great. What else? So any bradycardia, any significant bradycardia or significant tachycardia. AFib, very common cause of near syncope, sometimes syncope. What else? WPW. So anything that you're going to recognize as a potential cause of arrhythmias. WPW is an important one. You see short PR interval, you should think about that. What else? Long QT. There's a couple articles in here about long QT. What are the things that cause long QTs? Drugs. Which drugs? Zillions of them. Lots and lots and lots of drugs. Really important to be aware of this. A lot of people have a long QT. Usually it probably doesn't matter. But if they come in with syncope and they have a long QT, that's really high risk. By the way, there are a lot of drugs which cause prolonged QT even on very short usage, like erythromycin or azithromycin, or droperidol or haloperidol or any antipsychotic. Most of the SSRIs, most of the anticholinergic drugs, which is just about every drug in the world. So it's a very, very, very common thing to see a long QT. Most of the time, we don't spend much interest on it. But if you got it in the presence of syncope, you ought to worry about it. What else? A couple of articles about long QT in there. What else? By the way, droperidol, you all know it's black boxed, right? Anybody using droperidol anymore? Is it possible? How do you get it? You still have it?
Yeah, I still have it. I mean, it's a wonderful drug.
And do you have to get an EKG before you use it?
Unless I can talk the nurses out of it.
So what about if the patient's psychotic? Excuse me, sir, would you get an EKG so we... No, it is a great drug, and I just only mention this because the droperidol story is really a scandal. It's a great drug. It's cheap. That's its one bad sign, is it's cheap. Therefore, they got rid of it, and they got rid of it by giving a black box warning. And the reason I mention this is because it's sort of emblematic of what's wrong with how we act in the world of drugs. This is a drug that's very, very good. It does exactly the same thing as all of its companions. All the drugs we use for the same indications do exactly the same. They all prolong QT just as long. Droperidol was being used a lot as a competitor to risperidol, which has the other characteristic of being not as good and much more expensive. So if you're not as good and you're much more expensive, you have to have some way to make it an even playing field. And what the makers of risperidol did is they bought the generic company that makes droperidol, and they turned themselves into the FDA. I'm not making this up. It's a really big, we've done a lot of stuff in the abstracts about it, and it's a bad story. But in any case, there are a lot of drugs that cause prolonged QTs, and they can be dangerous. I don't mean to minimize that, although droperidol in particular has a tremendously good safety record. So you see somebody with syncope and they have a prolonged QT, that's high risk. That's not somebody I would treat lightly. Okay, what else on the EKG?
Brugada syndrome.
Which? Brugada syndrome. Okay, good. What is that? What is Brugada syndrome? Anybody know? Anybody ever seen it? Okay, so Brugada syndrome is this thing which was described, strangely enough, by Brugada. And it was this thing where they noticed that in some people who had sudden death, they seemed to have a funny-looking thing on the right side of the EKG. And particularly what you have is bundle branch. It was originally described as a right bundle branch block with ST elevation. It's not something you would expect to see very often. You see this, and my God, there were a few people who had sudden death. And from that original observation, people started making wild speculations about how common this was. And you'll see in this chapter, it says something about up to 60% of sudden deaths in Asia are due to Brugada syndrome, which I think is absolutely lunatic. I mean, I don't know how they made up this number, and I'm sure it is wrong.
Has it ever been seen outside of India?
It turns out the incidence, if you look for it, is the same everywhere. It was originally described as males. It's not. It's anybody. It was originally described as Asia. It's not. It's anybody. But I have no idea what it really does or what its importance is. I look for this now just out of interest, just out of fun. I look on EKGs, and very, very often. Oh, by the way, the definition has been expanded to incomplete right bundle branch block and a little bit of ST elevation. So it's not just the obvious case that you have an EKG in your manual. And if you actually look for this, you see it all the time. Well, you see something all the time, and very often you see what looks like a little widening, and maybe that's a right bundleoid pattern, and you can make it up if you want. The only good paper on this subject, the one that's really worth knowing about, is number 9. Here, it's not a great paper, but it gives us a little bit of a clue about something. They said, we took some people where we noticed Brugada syndrome on their EKG who had come in because they'd had an episode of sudden death from which they were resuscitated. That sounds pretty bad, right? We followed them for 7 years, and over 7 years, 4 of the 24 people who were resuscitated had another episode of sudden death and were dead. 4 out of 24 is a lot, right? Sounds pretty bad. Then they said, well, there's another 123 people, 63 people, excuse me, we found who had a syncopal episode, and we diagnosed Brugada syndrome. And in that group, 4 out of 64, or 4 out of 65, over 3 years had sudden death. Not nearly as much as 4 out of 24, but still pretty substantial. Although if you think about it, this was only 3 years, the other one was 7-year follow-up, maybe it's pretty close. So maybe if you have a major arrhythmia in association with this, most of the people did fine, 60 out of 64, but a few didn't, they died. So that sounds pretty bad. Then they took 128 other people who they discovered it incidentally, and one of them had sudden death. Okay, again, not 0. Well, by the way, it wasn't really so much incidentally. Some of them came in because of palpitations. They called them the asymptomatic group, but it was palpitation. Maybe that's the same thing. Maybe that was the one who died. I don't know. But why am I telling you all this? The numbers don't matter. What I'm telling you is it probably does really exist as a real entity. And when somebody comes in with high-risk symptoms and you find it, you ought to take it seriously. The only treatment, by the way, is an implantable defibrillator. There's no electrophysiologic treatment. But if you just happen to be getting EKGs and you find it, usually it doesn't mean very much. It's a little bit like ST elevation. When you see ST elevation in somebody who has a good story, it's a really important big deal, right? We call it ST elevation MI. When you see, a little bit 1 millimeter ST elevation in somebody who has a bad story or isn't complaining of chest pain at all, you call it early repolarization. The same is true of this. It's in the eye of the beholder. So why am I telling you all this? Because you do need to look for it. And if you see it in somebody who really had syncope and you really have a right bundle and a little bit of ST elevation in V1, you ought to take it seriously. You ought to know about it. But mostly, I think it's probably overrated. I think. Okay, what else? So EKG is really important. Testing. What other tests are important? Well, obviously, directed tests. If you're worried about hypovolemia, you should get a hematocrit, right? If you're worried about a brain process, they have neurologic dysfunction, you ought to get a CT. But in general, what we're worried about is arrhythmias. And the way we look for arrhythmias is we look for high-risk patients. Who are high-risk patients for arrhythmias? The old, those with a history of heart disease, or those who have some sign of heart disease right now. We're going to get to all these algorithms in a second, but they're all variations of things that make eminent sense. Old people are at risk. People who have a history of heart disease or currently have manifestations of heart disease, they're at risk. Okay? And these other things, these other big diseases that we talk about, you should look for them when they're clinically apparent. So then that takes us to this 11 through 16 or whatever it is, are a bunch of different decision instruments to help us decide which of these patients who come in with syncope we need to worry about. And they're all variations on a theme. And that is high-risk patients or those with high-risk findings. So high-risk patients are the elderly and those who have a history of heart disease. Those with high-risk findings have abnormal vital signs, tachycardia, bradycardia, abnormal EKG. Nothing here about CBCs. Or C-reactive proteins, or troponins. I get very frustrated when I hear people do millions and zillions of lab tests that cannot be helpful. Because when they're not helpful, they're harmful. Because they're harmful because they always give us false positives and lead us down silly pathways. So I just want to stress that this is not arcane stuff. It's not stuff where you have to remember a whole bunch of stuff. You just have to use your common sense. Be aware, on the EKG, if it's bad, you're almost certainly going to find it. If you don't find it, there's still a small chance it could be bad, but those are usually in high-risk patients. And they're either high-risk because they look high-risk, or because their EKG is high-risk. And the EKG findings are the ones we talked about, and EKG really is useful in this case, unlike so much of the rest of the time that we do it and other unnecessary tests. Any questions? Any thoughts? Comments? By the way, there are these rules that you're hearing about now, and the San Francisco Syncope rule was published a couple of years ago and gotten a lot of attention. I have a fellow at UCLA named Ben Sun, who's very smart and is doing a whole bunch of projects, including a big project on syncope, and we've been trying to look at these various rules, the San Francisco rule and a few other rules, and our findings don't look very good for them. None of the rules work very well. Either they have to be so inclusive that they're totally non-specific. You worry about everybody, anybody who's older than 7, or they miss patients. So I think it's much smarter to use your brain, because using your brain actually gives you the answer. And as always, make the appropriate caution that it doesn't matter if it sort of looks benign. It matters if you can tell yourself this is not dangerous. And you can't tell yourself it's not dangerous in the high-risk patients.